Good. Hi and welcome to everyone for this MI10 SOAP office hours. I'm Arlen Meyers. I'm with the Society of Physician Entrepreneurs, and hopefully Anthony and other folks will be joining us. Today's guest is Ali Abayazeed. Hi, Ali.
Hey, Arlen. Great to be here.
Yeah, good to have you back.
Thank you.
And Anthony, welcome.
Good morning, everyone.
Hey, Anthony.
So
Hi.
we're gonna so the topic for today is a couple things, but mostly burnout in radiologists. And so we'll get into it. And this is a conversation. So anyone that wants to raise their hand or ask a question at any time, please do. Yes, this is being recorded. Yes, this will be uploaded to the MI10 YouTube channel, which will distribute if you don't know what it is. So anyway, let's get started. So Ali, why don't you sort of give us a brief, a little walkthrough of your career and your sort of entrepreneurial journey and where that landed you right now.
Absolutely. Thanks, Arlen. It's great to be here with you and Anthony and everybody who has joined the call. So I'm Ali Abayazeed. I'm a neuroradiologist by training. I finished my fellowship in 2015, so I've been practicing since. My entrepreneurial journey started by just jumping off a cliff by co-founding a startup in AI where we built brain tumor imaging AI. So I've always been interested in brain tumor imaging. I have done a lot of work in that space during my fellowship and early career. And I was always fascinated by the fact that we don't have any objective. And I'm going to come back to this theme that I kind of realizing in my life. It's this objectivity of doing things through an objective lens and not just subjective way of measuring things. So I was always fascinated by we don't really objectively measure brain tumors on MRI through automated methods where we kind of standardize the assessment, but the radiologist and the surgeon and the oncologist will always debate how the tumor is doing serially over time, if it's getting better or smaller and so on. So that was kind of the very narrow use case. That was back in 2018. So CNNs were relatively new, and we decided to kind of build a model that will analyze all the brain MRIs that we're getting for patients with GBM or high-grade gliomas. And that's what we did. And we spun off a company of that. And I was with the company for about 5 years. And then I stepped down from my position at CMO. I'm still involved with the company as the co-founder. And then I decided to, during the 5 years that I spent with the company, I realized that I would like to learn more about management, about finance, about marketing, and dive deeper into clinical informatics and digital technologies. So I actually ended up joining Stanford. They have a great program called Clinical Masters of Clinical Informatics Management. It's basically at the intersection of healthcare management and AI and digital technologies, which is exactly what I was doing at the time. So I joined the program for about a year. It's a 1-year program, 12 months program, and it was fascinating. I learned a lot, met a lot of people, and started really thinking about AI and digital application in healthcare from a different perspective and a different lens, and more of a holistic view rather than a very narrow neuroradiologist view, and seeing the opportunities to make a true impact on clinicians and on healthcare and our practice at scale. So I graduated from that program last year. Went back to doing radiology. I do teleradiology. I've been doing teleradiology since 2022. Before that, I was in an academic setting. And I've seen over the past 10 plus years how the practice have shifted in radiology when it comes to the volume that radiologists are asked to look at, the number of images per study, how that has been increasing, the shortages that exist in healthcare in general, but specifically in physicians and very notably in the radiology practice. And I had a lot of conversation with colleagues, and everybody talks about burnout, but nobody's really to the extent where it should be is being evaluating it. And when we talk about AI or objective, again, going back to the objectivity of assessment, it's not really being objectively measured continuously and temporally. We can talk more about how there are these kind of a point solutions or surveys that gets filled every month. Again, not at scale. Maybe 10 to 15% of healthcare system in the country actually do that. The rest don't do it. So we can talk more about all of that, but yeah, that's kind of an overview.
Great. Yeah.
About my entrepreneurial journey. Yeah.
And the name of your company is Neosoma. At least it still is, right? I mean, it's still on.
Yeah, the first startup, yeah, is Neosoma. I started a new consulting business called QRadAI, and the goal so I'm the CEO and the founder of that company, and this is kind of my side gig, so to speak, or side hustle, even though I take it very seriously. And it's more about consulting, finding solutions to improve radiologists' workflow, whether it's by targeting their emotional, physical well-being, or it's targeting AI applications and workflow integrations with healthcare systems and with private radiology groups.
Right. And just so people understand, you're an academic neuroradiologist at UMass?
I used to. So I no longer work with UMass. I was at UMass for about 6 years. And then I had to step down to be full-time with the company, with Neosoma, when I was the chief medical officer. And then I went back right now to doing more of a teleradiology work with Sharp Healthcare in San Diego and PIH in LA, but I work remotely from the Boston area.
I see. So that's an interesting career path.
Yeah.
So we have a lot to talk about. So why don't we start off with the subject at hand, and that is, in your opinion, does ambient AI improve or make worse radiology burnout?
Well, ambient AI doesn't really impact radiologist workflow. We've always had our own voice dictation systems. The most commonly used is called PowerScribe. We don't really interact with ambient AI. Maybe on the interventional radiology side, that would be an area of use for ambient technology. But overall, I would say, based on what I've seen and what I've read, that ambient technology is kind of a mixed bag. It depends on so many factors, whether it's actually going to improve your work-life balance or not. It depends on how it's integrated. Which tools are you using? Is the workforce educated about using the ambient technology or not? How accurate is the output? And how deeply it is integrated within the workflow and seemingly integrated within the workflow, so you're not dying by 100 clicks. So there are some studies that have shown that it does have improvement on the mental load, not necessarily on the time spent on note taking. And there are others that have suggested that it actually contributed to an increased time of work for clinicians. So I think it's early. We're still in the early days of ambient technology. This is just going to get better and better as the underlying core models improve, but also as when we start learning more about how to use it and how to use it effectively and start using it at scale. So I would say the future is bright when it comes to ambient technology, even though the current data is kind of mixed on how impactful it is.
Yeah. So can you see this up on a screen?
Yeah.
Okay. So just for grins, I thought I'd pull this article up and get some comments from the peanut gallery. So this is an article that appeared in 2024. And of course, we're aware that the burnout data shifts from year to year to year, pre-COVID, COVID, post-COVID. Every year it seems to be different. Yeah. So the latest information, and there's a survey done every year by Medscape that asks this question of several thousand doctors. And to give you the headline, about half of doctors of all specialties, roughly, experience what is typically described as burnout. And we can get into the issues of what it is, how you define it, but let's just agree that that's what it is. And radiologists actually, in 2 years ago, 3 years ago in a survey, were seventh. So number one, burnout varies from specialty to specialty. Number two, as you would expect, the people in the front lines, primary care, emergency room doctors, that kind of stuff, they have the highest levels. And number three, the levels seem to have dropped by a couple percentage points, not radically. So this one looks at, well, does artificial intelligence, in fact, increase or decrease burnout? Let me just point out that this article, if this makes any difference, and Anthony, maybe you can chime in on this, is from a group of Chinese radiologists and informaticians. And the bottom line is, you can look this article up and go through all the analysis, but the bottom line is that it actually made it worse. Now, not a lot, but it actually, when you compared AI use and non-use of radiologists, their conclusion was that AI actually made it worse. So, and let me just point out that in the limitations, there's a whole bunch of limitations in every study. So, you can't take this, just for face value. I guess you have to look into the details. But they weren't typically overwhelmed with the ability of artificial intelligence to reduce burnout in radiologists. So let's just stop there for a minute. So Anthony or anybody else, do you have any comments about this article and their conclusions?
Well, as you said, Arlen, I think it depends on the subspecialty and what your workflow is. The last 6 months, been to a lot of different meetings and panels and giving talks. I would say overall, the use of ambient intelligence has been a pretty sizable hit, positively. And I'll forward you an article that I think just came out recently, surveying physicians. So I think perhaps there's something about the radiologist workflow or the dynamics with ambient that's different than, let's say, in a primary care or a subspecialist in clinic. But overall, the impression I get from the users has been overwhelmingly positive. Matter of fact, it's been a deal maker for a lot of groups to adopt ambient intelligence, including our own at my hospital. So I would say overall, the other subspecialist experience has been maybe somewhat different than the report that you just talked about.
Okay. Teresa, do you want to introduce yourself? Teresa, are you with us?
Yes, hello.
Hello. So just, give a one-sentence introduction to who you are.
Sure. I'm Dr. Teresa Sizurek, and I am a innovation strategist, especially helping organizations, including those in healthcare, introduce innovations such as AI to improve performance. And so I have been speaking on this, and now I'm organizing all of the data and case studies that I can and bringing this out to try to educate and make an impact. I was the state of Colorado's chief information officer, and I'm a 3-time tech entrepreneur, by the way.
Right, with several exits.
Very nice meeting you.
Right. So Teresa and I are collaborating on a couple things, and she recently gave a presentation to a bunch of tech execs. But the question I want you to sort of answer, Teresa, your sweet spot is dissemination and implementation and deployment of these technologies, and that's a subject for another matter. But when it comes to ambient AI and artificial intelligence in healthcare, in your experience, what would you see as the single biggest reason that an AI deployment fails?
Mhm. Well, from my research, secondary and primary research, I'm finding that it's the leaders in the organizations who are not moving fast enough to fully embrace the solutions, the artificial intelligence, and that the end users, in this case, the doctors, are ready to get the help, but sometimes the leaders in the organization can be the obstacle.
So how are you fixing that, or how are you addressing that? I mean, lousy leadership is not exactly a new idea. So what are you doing? What do you suggest?
Well, first of all, you need to identify the issue. I suggest using social change theory, which was brought together by Kurt Lewin in the 40s in World War II. Conduct a force field analysis in your situation that identifies the positive forces increasing the use and the negative forces decreasing the use. Once you have this force field analysis, take a look at the positive and negative forces and identify strategies that can help reduce the negative forces. Like, for instance, here today, you were talking about Dr. Allie was talking about some of the positives, that it decreases the mental load, but it's early on. And I think actually transferring three things help. And this was based on my research published in my first book, Champions of Technological Change. Having the right product that can really be easy to use. Secondly, having the right information or training. And third, the right rewards. In this case, helping decrease the mental load, saving time, etc. Can be the things that are strategies to decrease the negative forces and therefore allow the adoption of AI and more of it.
Based on what you've seen, sorry, Arlen, I just would like to, hi, Teresa.
No, go ahead.
Very nice meeting you, first of all.
Hi.
Thank you for being here. And I wanted to ask you, so when it comes to, for example, decreasing mental load, just focusing on that kind of a behavioral or emotional impact, which is part of what burnout is, emotional exhaustion, depersonalization, and low sense of self-accomplishment. This kind of the three dimensions of what burnout is. How have you seen that being measured on the ground in those healthcare systems? Because that's kind of the core of what really I'm interested in, understanding how this is being measured from other people's perspectives.
I don't have a detailed answer. It is an excellent question. And I think each organization will measure it differently. Sometimes it's just a scale on a 1 to 5. How burned out are you feeling? Giving a very high level measure of burnout. And I think we need better definition and better measurement. How are you on the call here finding burnout being measured in your organizations?
Yeah, please jump in.
Yeah, that's a good question. So, Ali, why don't you start at your place? I mean, when you were at University of Massachusetts, you said you never got a sheet
nobody ever gave me like an MBI survey, the Maslach burnout score, which is kind of the most famous one to be used, or even the newer version, which is the Mayo Clinic Wellbeing Index. Nobody has ever told me, hey, fill this out. And even if they did, I really doubt the value of doing this at one point in time, once a month or once every 3 months or once 6 months. It doesn't really capture what you're feeling throughout the year, for example. And it's a survey, and there's no, to me, there's no physical data inputted into that survey. It's purely subjective, And maybe today, while I'm filling the survey, I feel really bad. I had a disagreement with a colleague or my boss that day. How will that survey look like? Right?
Yeah.
So yeah, no, to answer your question, I don't see it being objectively measured, even though we always talk about it and we say AI will improve burnout, but how will you measure the AI improvement of burnout, even with these kind of very random single point of time surveys? How will you say objectively, oh, it did really improve? So I don't see that.
Susan, pediatricians are cited as having one of the highest rates of burnout when these things are done. Can you give us your 2 cents?
Well, I just also want to, before I give my 2 cents, I want to ask Ali and Arlen, has anybody done a study comparing concierge practices to the general physician practices in the area? Because if you talk to concierge practices, maybe a totally different
By
answer.
concierge practices, do you mean like the One Medicals of the world, for
Yeah,
example?
direct primary care, concierge medicine.
I'm talking about doctors who give a choice to a patient. You pay me this much per year.
Right.
Our group,
Okay.
I myself will be on call for you 24 hours a day. It's a limited group of people who can afford that. And I'm wondering if anybody did a study comparing the two models. And as
Yeah.
a pediatrician,
So let me just answer that question. So the short answer is yes. Now, again, how they did it, the validity of the study, can you believe it, et cetera, is another issue. But yes, those things have been done. But, this term direct primary care, concierge medicine, retainer care, it comes under a lot of different names. But the substantive idea is, for those that are not familiar with that model, is that instead of you're going to see a doctor and doing it the routine way, you pay, in some instances, an upfront fee to join the panel of that doctor, and that fee can vary from a couple $100 to a couple $1,000, depending on who it is and where it is. And then you have an ongoing monthly fee to retain supposedly premier first-class access to the physician. Most of these are primary care doctors. The latest data was that about 6% of primary care doctors are embracing the primary care model. The primary care model is basically of 2 types. One is a hybrid model, which means part of my practice will be direct primary care, and I'm going to continue to do it routinely and accept insurance the way everybody else does. The second model is no way, no how am I taking insurance. This is all direct primary care. You pay me the upfront retainer, you pay me X amount of money every month, but when you call me, I'm going to return your call on a cell phone in 20 minutes, and you're going to get an appointment the next day, et cetera, et cetera, et cetera. So it's like VIP lounge care. There are all kinds of ethical issues. Is it scalable? Is it really ethical? What's that going to do to the healthcare spend, et cetera, et cetera? But for this topic, finally, to get to the bottom line, people who are doing direct primary care alone, yes, they say they are less burned out and happier and have a better quality of life than those that don't. But it's a complicated, like everything, there's all kinds of variables and everything else. But so let's get back to my question to Susan. What were you're muted, Susan?
Oh, yeah. As a primary care pediatrician, and we see onwards about 20 to 40 patients per day. That's what pediatrics is all about. I have an independently run practice, so I manage my time based on our experience in the practice. And so I feel a lot less burnout maybe than my colleagues who belong to large hospital systems and so forth. But I do believe that ambient AI can help me in a very important way. If I, and I'm thinking of developing this idea, have a medical assistant AI take on the information, and before I go into the practice, without having a medical assistant go in and then a nurse, I feel that I would be better prepared to help that child reach the specialist or reach the information that they need versus me going in and repeating the same questions. What we all do as physicians, we don't have time to read the medical assistant's notes, so we ask the same questions and it wastes a lot of time. So I want to cut that middleman out. That's all.
Right, right. So this is basically a digital clipboard. So Anthony, my understanding of agentic AI and other models of training artificial intelligence, and maybe you can relate to MCP, whatever that is. So to Susan's question, the vision, as I understand it, is to do exactly what she said. So using artificial intelligence to gather the information, not just during the visit, but before the visit, during the visit, and after the visit as a continuum of care. So essentially you don't have to go through the whole thing again. Like she said, like, what's the point of asking the same questions, whether it's on a clipboard or via a microphone? So maybe you can address that issue and sort of clarify some of that for us.
Yeah, this is why I've been writing and talking about the coupling between Gen AI, generative AI, and agentic AI, and I have great hopes for healthcare, because healthcare, as you know, 30% administrative cost and burden, and not terribly efficient. So I think that's where agentic AI, the strength of agentic AI is actually executing what you have in mind. So in other words, think of Gen AI as the coach on the sidelines, and agentic AI, simplistically, as the autonomous quarterback on the field that carries your philosophy. So any primary care provider or subspecialist like myself spend a lot of our day executing on these tasks that really can be done by a relatively smart agentic AI tool that will execute things like setting up appointments or follow-ups or looking after lab tests and things like that I have to deal with on my phone all the time. So I think that's going to relieve quite a bit of the burden if it's done correctly. Now, we also can't let the autonomous AI agent go off without guardrails, because then you can end up with a potential negative situation. So, but I think there's a lot of tasks that providers are doing right now that can be safely delegated to smart tools that can be coupled to your philosophy.
So there was a recent article in the Harvard Business Review about this issue of agentic AI being a fiduciary of the agent. The argument is, if I'm going to delegate these tasks to a computer or an algorithm or whatever, how do I know they're going to do what they want them to do? And if they don't, how are they held responsible? So do you see that as being an issue?
I think yes and no. Ironically, I'm writing a piece on the trust that we have. I know there's increasing discussion and writing about these AI tools having some characteristics of scheming and sandbagging and all these terms now. Interesting, they all start with the letter S. That they're kind of on their own trying to do something to perhaps preserve their existence, right, and survival. So I do worry about that, but I think as long as you set guardrails and have human oversight, I think it should be okay, at least with the easier tasks. I wouldn't trust it with the more complex tasks because there are a lot of nuances there, but I think with the easy ones, for sure.
So can you explain to us, or maybe Harvey or someone else can explain what MCP is and why should we care?
MCP is huge.
Yeah, what is it?
Model Context Protocol. So it came out of Anthropic, and the goal was to be that kind of a USB hub to your laptop. So you can integrate, the data that getting transferred in and out, so the I/O of any model, you create that protocol where you can use any model and it will basically understand what you're trying to do. So it's kind of, you can think of it maybe as I don't know if Anthony can correct me, or Harvey. The way that I think of it also is like it's the API to LLMs. And I want to go back to one discussion. I don't know if anybody has actually tried on the call, have tried to build any agents, and I would like to get your input because I've been struggling to build an agent. I use M8N as a platform for agentic workflow. There are plenty of them, but they always fail. They always fail, no matter what you're trying to do. And especially when you add multiple steps to their workflow, they always fail. And you have to spend a lot of time trying to figure out why they failed and to fix that. And that's one of the issues, going back to the start of the call, which is, how much time are we really spending with AI versus spending on our own? So, and I'm not sure that LLM is the right architecture to actually do agentics. There are a lot of new architectures that are being discussed. For example, the large concept model by Yann LeCun out of Meta. And I think there's a potential there for a better architecture than the next token LLM to do agentics. I'm not sure that I'm not sure that LLM as an architecture will be able to do kind of the complex task that we believe it will do. Even with the plethora of agentic platforms that you can build agents and MCP and all of that, I think it's the right direction. We're all going in the right direction, but there has to be some foundational model innovation to get us to that agentic utopia that we all believe we will live in 5 to 10 years from now.
And Harvey, what's your 2 cents?
Yeah, so I just wanted to add, so MCP, what you said is correct. Big picture, think of it this way. Like you said, the API, but it's even more than that. Windows is going to add that to your computer. And so everything in the future should be integrated. All of us, think of us as, we're different specialists. Well, the same with the AI. Now there's a platform to talk, and now it's even better. While we're not even here, our models can talk to each other, and then we can be more efficient. And then to your point on creating AI agents, you and I could talk offline and I could give you some tips and stuff like that. But it's huge. You guys don't understand how big this is going to be once this MCP gets going.
MCP.
All right. So Anthony, you have referred to this as, I don't want to belabor this too much, but USB-C for AI tools. And I think, so maybe you can just elaborate on that. What do you mean by that?
Me or Harvey?
Anyone.
Well, it's basically you have an interface where you can integrate so many tools with the LLM of your choice.
But
so now you don't have to prompt the LLM in a certain way. You don't have to send them the information in a. So I can use OpenAI, I can use Anthropic, I can use whatever LLM through that single common interface. And I can also, like Harvey said, I can route the information from one LLM to the next and get a kind of a more of an aggregated output.
But to Susan's points, and my understanding is, so in the best of all possible worlds, any piece of information, anywhere, anytime, any place that has to do with a patient's health gets aggregated into the big brain in the sky. And that is accessible anywhere, anytime, any place, before, during, and after the visit. Now, that's a simplistic surgeon explanation. Am I close to what this is about?
Yes. Yeah, close.
Okay.
But here's the thing. You might have a model that is very good at understanding a certain context or a certain disease process or a certain workflow. So the question is how to use the best of every model in every context jointly in one orchestrated workflow. That's to me where the power of agentics and MCP come into play, because now you have these multiple models that all converge each of them to do the best that they can do to reach a certain goal, and understanding the context of that. And that's where I think LLM fail, the context piece. That's where the bottlenecks are usually for LLMs. In my experience, I'm not an AI developer by any chance. I do a little bit of coding, but I'm not an AI developer. So, this is just my experience.
Yeah. Anthony, you want to elaborate on your USB-C comment?
You know how we've been really struggling with different connectors all the time, with different things.
Right.
So now more and more things are USB-C. So I look at MCP, again, this is very simplistic in terms of the AI architecture, as providing an open platform so that these AI tools can communicate and data streams can communicate with each other. So in a way, it's kind of like decentralizing rather than centralizing, as you were saying, decentralizing AI so that it's more accessible in terms of getting the data to come in and do something with the data and then push an output to wherever it's needed. So it's definitely, the connections are much more efficient, hopefully.
This kind of reminds me of the days when if you had an Apple, you couldn't talk to Microsoft. And then they eventually figured out they both could talk to each other, but you had 16 different connections and USBs and God knows what. And then they standardized the connections. So eventually we're moving closer to pure data interoperability accessible through a single port or a single fiber a pathway. Is that essentially what you're saying?
Yeah. Data and you do with the data also more important.
Right. Okay. So let's assume that this is going to happen if it's not already happening now. So let's get back to the question at hand, and that is, well, what impact would all of this have on burnout? And what are the unintended consequences of doing this? More importantly, or not as importantly, what is the cost? So let me just remind you that back in the day, and still, we have spent billions of, meaning US taxpayers, have spent billions of dollars deploying electronic medical records. And every single time you ask a doctor, what do you think is the single biggest reason you're burned out? They say technology. I hate the EMR. So now we've created ambient AI to deal with not having to type in the computer. So that seems to me like a case of treating the symptoms and not the disease. Now, how much is it going to cost us to treat the symptoms instead of the disease? In other words, all of this money is going into ambient AI, and everybody thinks it's the panacea and the greatest thing since sliced bread. But in my opinion, it doesn't treat the root cause. That is the way we aggregate and analyze information in the sick care system. We're stuck. I'm not going to, in my lifetime, see the end of electronic medical record. Maybe there will be a different iteration of it. But my concern is, and number one is, what is it going to cost to treat the unintended consequences? And number two, to the main point, is it going to increase or decrease burnout? Because now Susan is going to get a ton more information or data than she did before she was seeing the patient actually in her office. So what do you think? Ali?
It would make it easier for me if I had the information in front of me of what's wrong with the kid. Sometimes the medical assistant is not able to answer all the key questions. And if AI can jump in, the different models that Harvey and everybody here has been talking about, they can communicate with each other. Give me an idea. I have a kid with a stomach ache, vomiting, high fever, no diarrhea. So then the model that would predict, you should look into these factors like appendicitis, etc., would make my life easier. It would just alert me to things that I might miss because the day is just so busy and there's just so many patients waiting.
Yeah, no, I totally agree with Susan. And I also agree with you, Arlen. I think I don't really, I don't know, I don't perceive AI scribes are this huge revolution that everybody sees it, or not everybody, most people see it that way. I think that's the normal progression and innovation of electronic medical record, just using the most current technology. That was kind of the expected next step of what's going to happen to EMR when LLM showed up. You're going to use that to do AI, you're going to use that to do ambient technology. That was just the logical next step to some of the deficiencies that exist in EMR. But even then, even when you use this ambient technology and you're automating some of this note taking and inputting it, EMR is still, you're still dealing with the same data exchange issues that are the core problem of why EMR fail at scale in dealing with patients, especially when patients move from state to state or from one provider to the next and from health system to the next. This data is still inputted into the same AMR, and you're not going to be able to easily exchange it and access it. So the data access, which is the core problem of electronic medical record, is not solved by ambient technology. And I don't think anybody's working on solving it, to be honest. Even Epic is probably not interested in solving it because it just locks in their customer. So don't take my word for that. I'm just not seeing concrete movement in that direction. So I think ambient technology, but going back to really the first principle concept that I'm thinking about is that even, let's say tomorrow, you have all these AI agents and you have all these ambient technologies and you have the digital twin that Harvey Castro was talking about. And that's an exciting future, of course, for all of us. At the core is still, how are you measuring the impact on the workforce? How are you dealing with this up to 70% burnout rate in physicians? How are you dealing with the projected shortages of physicians over the next 2, 3, or 4 decades? How are you really objectively measuring the impact of those AIs before deployment, after deployment, when you're not objectively measuring their burnout and their workload? I think there's a pathway for wearables to have more and also in addition to more short-term surveys, maybe every day is just a notification on your phone, to like the 1 to 5 Likert scale that Teresa was talking about. You know, how much burnout do you feel today, plus all this wearable data from your watch, from your Oura Ring or whatever, to correlate your stress, your sleep, your energy, your exercise, and give you more of a score that you can look at every day. So you at the personal level can actually do some changes. And at a system level, the leadership can also help you with that, because studies have shown that you need both to be able to be successful. You need that personal level of awareness of where I'm at physically, emotionally, and career-wise. And you need the leadership support and view of what's going on with their workforce to be actually successful. So it's great to be talking about AI scribes and MCP and all of that, and we should have those conversations, and these are very important conversations. But when I kind of reflect on myself and how these AIs are actually being implemented and used, and what does that mean to me at a personal level, I really don't know if we're looking at an objective way and a meaningful way of measuring that impact on the individual to make sure that the collective really works.
There's another conversation that's going on that has to do with people, the so-called younger generation, not wanting to work as hard as the older generation.
Come on, that's not true, Arlen. Just because you have white hair and I have black hair, that doesn't mean I don't have to work as hard.
Wait, I'm not done. I'm not done. And Greg Murphy, who is a urologist, congressman from North Carolina, Republican, he likes to stick a finger in the eye of this conversation, and he's complaining that young doctors just should shut up and show up. My point is that if you look at the information that most doctors quit, or they not because medicine is hard, we all kind of accept the fact that's what we signed up for. The thing that the main thing that happens and why they quit is, one, they don't feel valued. And two, it's not what they signed up for. The system just makes it a hard profession even harder. And we don't understand why someone doesn't fix it. And yes, we understand that medicine is hard and sometimes, and there's these 8 levels of wellness, and the Mayo Clinic is all over this with apps and all that stuff every day. But I think we're treating this, and it doesn't help when you declare war on science and war on doctors and war on everybody that doesn't have anything to do with saying and doing what you want them to do. So again, this is a multi-dimensional problem. It's a wicked multifactorial problem. And in some instances, I think we're missing the boat. And someone commented, does anybody in leadership really care? I mean, is this just to your point? Everybody talks about it, but the leaders just seem to be so focused on return on investment. How many points are you putting on the board? Are you showing up and doing what we expect you to do? Stop complaining. You're lucky you have a job at all, let alone being a doctor, et cetera, et cetera, et cetera, et cetera. Peter Horn, can you give us a view from the other side of the pond? So for those of you who don't know Peter, he's got a fair amount of experience working in the NHS. And incidentally, a lot of Americans are now transferring their citizenship to the UK because they're sort of fed up with what's going on. That's another conversation. But can you give us sort of a brief overview of, because we're talking about the United States. We're talking about burnout of doctors in the United States, arguably a privileged position. And maybe in the UK, but when you talk about South Sudan, Sub-Saharan Africa, Mozambique, you name these places that, they have no access to this stuff. So what's going on in the NHS? And maybe you can give us in this topic, artificial intelligence and burnout.
Thank you for that, Arlen. Hello, everyone. There's a few friendly faces on there as well. And when you started talking about the younger generation, I presumed you were talking about me.
Of course.
But yeah, I mean, the NHS at the moment it's in a bit of a mess, and people sort of see all that. So when it's in a bit of a mess, what do the politicians do? They organise another restructure. So that's what's going on, and I think the part of the issue for within the NHS is it's very difficult to innovate, and yet clinicians coming up through the medical training and all of those sort of things, I think they are desperate to want to be able to innovate, be able to work in different ways. But the orthodoxy of the people who've been around a bit longer, a cultural orthodoxy, I think, gets in the way of some of that. That's one point. Second point is I think there's not enough money kicking around over here at the moment. And you would have thought in the way that the NHS works, which is you can't trade your way out of the problem because there is no, all you're doing is trading your way out of the problem with somebody else's money, but it all comes out of the same bucket. So actually that you can't trade your way out of the problem. So I think with the crisis, the opportunity is there, but the NHS seems to be caught up too much in its process and the way it sort of, particularly within hospitals, the way that there's an orthodoxy around the way a patient is treated, there's no real incentive to be innovative and productive. So it's I think it's a very similar issue, and there are changes now, particularly with the people coming up through the system. Their expectations are different, but I think there's a bit more about people wanting to actually make a difference and not be prepared to run with the orthodoxy of this is the way we do it around here, and actually to say this isn't the right way to be doing things. It's the model's broken. I think, or I suspect, talking to some people, there are going to be opportunities, therefore, for people to be a bit more sort of tech savvy, or try to harness AI in a way that helps people to actually treat patients. So not get in the way.
Good. So
As it
thanks
were.
thanks for that. So Anthony, you've been traveling around the world talking to young people. So give us a report from the trenches. What's your sense?
I think we need to be cautiously optimistic to help them with our wisdom. And they're definitely very savvy. I just got back from Turkey and Istanbul. They're very savvy with some of the tools already. So I think we underestimate continuously how they're empowering themselves with these tools, even in what's considered some of the countries with less resources. They're finding ways to leverage AI in many different ways. And these are first to fourth year medical students I spent time with this past week. They're already using a lot of large language models, and learn that way.
Can you tell us one example, Anthony, that you saw?
They are using in a clinical setting GPT to help them come up with a differential diagnosis and teach and learn from each other. That's very common, much more common than I expected.
That's great.
Good.
I mean, I'd say, sorry, just adding to this. I mean, I think you know what I'm about to say, Arlen, but I think there's something about getting behind these people and causing a bit of a revolution, actually.
Yeah. Right. So, Ali, I want to go back to your point. Well, before I go on, is there anyone in the audience that wants to comment on this, particularly if you're a resident or someone just into practice? Is there anyone in the audience that wants to impart any wisdom or how they see this going? Daniel, you want to give us your...
Are there any radiologists?
Hey, Arlen. Thanks for the shout out. I'm Dan Burke. I'm a critical care doctor, certainly not just out of practice. I've been practicing for 10 years, but, I did want to comment a little bit about, you bring up these great points about physician burnout and, the amount of information that is available to us at any given time for any given patient. And I do agree with you. Part of that is, centered around the EHR and why physicians, we all hate the EHR so much and why it's this, this our great enemy. But, one aspect of information that I know actually, Anthony, you talk about quite a bit, and I think it also is a huge contribution to our burnout, is just sort of the amount of clinical information that we are expected to know about all diseases at any given time. And, I know it's been written about in many books, Chaos in Organization, Healthcare by James Morgan back in like the early 2000s. He wrote a great book about this. And it's almost like we're like the victims of our own success. We produce so much literature, and it's the amount of publications we have are growing at an exponential rate. I do feel like we can't really blame the EHR for that. It's certainly just the amount of information. And I know personally, I think all physicians, we hit a point where we hit our saturation level, where we can't really expect to know everything that's around us, even for our own specialty. And I do think that's a big part of why a lot of docs get burnt out. And I do feel like that is one area where, we do rely on AI quite a bit already to kind of help address that. And I almost don't think of it as addressing the failure of EHR. It's more of helping us catch up to what information is slipping through our fingers at any given day.
Great, thanks for that. Ali, are you still with us?
Yeah, I'm right here. Can you not?
Oh, great. I want one final thing before we only have a couple minutes left, 7 minutes. I want to get back to your taking this thing at Stanford. And, I'm a big fan, obviously, of the intersection of the business of medicine, informatics, and healthcare. So what is the take home from? So basically, you're involved, and I'm and others on this call, in the business of informatics and healthcare. So what are the top couple take homes you got from doing this?
Oh, okay. That's a curveball. Okay. No, I think I would say
you can hit a curve. I know it.
Yeah. Sometimes. I think the top two takeaways is business people don't really understand healthcare the way physicians do, which seems obvious, but you will be surprised how how people are just purely on the administrative and business side think they know healthcare, but they don't. Just because they had one interaction, they went to the hospital a few times, or they see their primary care physician, or they had a surgery, they think they kind of understand the complexity of healthcare. They don't. I had the multiple numerous actually conversations with people from the MBA program at the GSB who are interested in healthcare, and it was always enlightening to them to see our world from a physician perspective. They really don't get how complex it is to do something in healthcare, and to get a product to a healthcare, or to build something in healthcare, and the things that you need to think about, and the different organizations and regulations and so on. So that was a big theme. The other big theme is the fragmentation that currently exists in the informatics and the digital landscape in healthcare, and how a lot of the applications are living in silos and are not really communicating efficiently with each other. And that goes back to the HITECH Act and the implementation of EMR, which in hindsight was significantly flawed, but it was very hard to see it at that time. I think it was very rushed, and it needed more of a thought process. And I think AI might fill some of those gaps of fragmentation, but the system is going to remain to be fragmented. And there's no workaround that fragmentation. We reached that level where it's going to be very hard to make it more homogeneous and work more seamlessly. But we can do the best that we can. And I think that's where AI and the future of digital technology is going to be, this is where digital technologies and AI is really going to succeed, and we're going to have adoption in healthcare, is when you deal with these areas and fill those gaps between the currently existing technology.
So one final question is, we're hearing a lot of conversation about, should I get this degree? Should I get an MPH? Should I get an MBA? Should I get an whatever. And everybody kind of does their own personal cost benefit. I mean, I don't know what this program at Stanford costs, but I'm imagining it's costs a lot of money. I mean, you can tell us if you want, but it's up to you. But anyway,
it's about 80K.
80K for 1 year virtual program?
No, it's on site. But it's you go for a whole weekend every 2 weeks.
Right. Okay.
Yeah.
So $80,000. So if you are considering, for whatever reason, that you want to get deeper in the weeds in this subject, what advice would you give to people who are considering doing what you did?
If you can do the MSIM, 100%, you should go for that, especially if you're in that space that I believe we're all in right here. I believe just a pure MBA unless you have a very strong, wherever you're going to do the MBA, there's a very strong healthcare track that deals with the complexity and the issues related specifically to healthcare, given that it's completely different from any other industry, then you can go for an MBA program. But if that MBA program doesn't have that, then MSAM, which is basically a healthcare MBA with a digital technology backbone, is really where I believe you should be. And there are two programs currently you don't have to go to Stanford. There's one out of Duke. It's called the MCMI, and it was also started by Dr. Schulman, who started the one at Stanford when he moved to Stanford. I think these are the only two programs in the country that actually sit at that intersection. And I would highly recommend doing those programs over an MBA that doesn't have a very strong healthcare track.
What some of the again? Tell me the name, please.
It's called MCIM, Masters of Clinical Informatics Management.
Yeah, thank you.
One of the things this is Teresa again, and this might be
Teresa. We only have 1 minute left.
Okay, it's the role of the physicians working with the people in the office of IT. Rather than inventing it yourself, how can you partner with the people who know the information technology, the CIOs, to bring out the right solution?
Yeah, I think we all agree there needs to be more cooperation and play nice together. Finally, I do think we're going to, there's another program at University College London, which is a business of medicine, strictly business of medicine school. And that has attracted a lot of attention, and we don't have time to go into all of this, but I do think more and more of these programs that are the intersection between healthcare, informatics, and business that are very, very specific and address the needs of the people that go there, we're going to see more and more of that. We don't have time to talk about all the other programs, but in my opinion, including medical schools, I think they've lost touch with their customer base, and more we're seeing transition. So anyway, this is a great conversation. Thanks to everybody for your 2 cents. Teresa, nice job. Everybody else, and hopefully,
Thanks, Arlen.
Yeah, we'll see you next time. Thanks very much.
Thanks, everybody.
Great to see you.
Thank you.
Bye.
You too. Bye.